Hello everyone, Thomas Wimes here from Santa Barbara Nutrients. It was my great pleasure to sit down with Dr. David Unwin for an interview. Many of you, I'm sure, know about Dr. Unwin. He's an award-winning general practitioner and known for pioneering ketogenic metabolic therapy in the UK. He's a senior partner of a clinic in Southport that is part of the UK's National Health Service, or NHS. And Dr. Unwin is really considered one of the most influential general practitioners in the UK and is also recognized worldwide as an expert on the topic of ketogenic metabolic therapy and type 2 diabetes. He published numerous papers in the scientific literature, including one that caught my attention when it came out. That was on the effect of ketogenic metabolic therapy in kidney disease. And spoiler alert, it does not make kidney disease worse. So Dr. Unwin received numerous awards, including the 2016 NHS Innovator of the Year Award for his research and work with diabetic patients. He's also an expert clinical advisor on diabetes to the Royal College of General Practitioners. And Dr. Unwin is really a rock star in the metabolic health community. He has 90,000 followers on Twitter and is just you see him everywhere on YouTube and so on. Very influential. And I met David recently in the last fall in Switzerland at a Keto Live expert workshop. We're both involved and on the advisory board of this organization. This expert workshop was really fantastic. And Dr. Unwin led the whole workshop, so it was great to get to know him there. And I'm now very happy and honored to be able to pick his brain in this interview. Enjoy. Hello everyone, Thomas Wimes here. It's a great pleasure and honor to have a very special guest today, Dr. David Unwin from the UK. So David has been an amazing driving force in kind of the low-carb community and, has not only practiced what he preaches, but also published lots of papers on it and done the research, done the science. So I'm really excited, David, to have you here and pick your brain. So welcome, David. We met a few months ago in Switzerland at a Keto Live workshop. That's an organization we both are involved in, and you were leading the workshop, and it was just, to me, just amazing. All the things we discussed there. So it was like a very high intensity workshop. I think it was called the Expert Week or something like that, and it was just amazing to have all these experts around the table, including you. Good. So let's first, maybe for folks in the audience that may not know who David Unwin is, let's figure out who is David Unwin. And I wonder, maybe you could fill us in real quick, where you're from, what you did all your career long, and what happened sort of more, somewhat recently in the last, maybe decade or so, that changed things for you, and what the story behind David Unwin is.
With pleasure, Thomas, with pleasure. So I'm an oldish GP. I'm practicing in the UK about 10 miles north of Liverpool. And in fact, as I sit here now, the sea is about half a mile away. So we live at the seaside. I've looked after the same population in Southport, the town here, since 1986. So many years. We've got a practice of about 9,500 patients, so we're kept very busy. For the first 20 years, I practiced very conventional medicine, really, but it was largely, I would say, drug-based, medication-based. And then a single patient changed my life. I was always interested in obesity and type 2 diabetes, And then one of my patients was not taking her medication, and I brought her in to tell her off. And to my astonishment, she proceeded to tell me off. And she said that she'd normalized her diabetes and come off all her medication and lost stones in weight with this weird diet, the low-carb diet. When I did the blood work, she had indeed done all those things. Her anger was because I'd prescribed medication for her and never ever discussed the fact that starchy carbohydrates like bread and potatoes and breakfast cereals are sugar. And she'd given these up, which is the basis of the low-carb diet, and increased things like green vegetables, meat, fish, eggs, full-fat dairy, and had put her diabetes into remission. And that's the first time I had ever seen that. I didn't know it was possible. I was, as I say, astonished. And then I went on the diet myself, and it really suited me. I was amazed. And then we started, my wife and I, with patients in the practice. And then we began really a clinic which uses the low-carb diet for any of our patients with diabetes who are interested, which there are now hundreds of them. And we've been collecting very careful data for 10 years now. And we find out many surprising things, and that's the basis of the papers that you mentioned. So I think you're more or less up to date, Thomas.
Wonderful. Well, great. Thank you for that, David. So that's actually an amazing story, I think. So, to recap, you're a general practitioner working in a clinic in, a small beach town in the UK, maybe similar to Santa Barbara, perhaps. I'm not sure. I haven't been there, but it looks lovely on the map. Um, and you've been practicing there for, many, many years, treating people with, the usual chronic diseases, obesity, diabetes, using the conventional approaches, here's this drug, here's that drug, knowing full well that it's those patients usually don't reverse their disease, they don't actually get better. Um, and one day a patient shows up and yells at you for saying, "Why didn't you tell me about this diet?" And that told you about this diet, I guess, about the diet intervention. So that, I think, to me, tells me also the power of what one individual patient can have
Absolutely.
over the system, so to speak, by essentially advocating for themselves and bringing something to the attention of their doctor. But I think it really takes an open-minded doctor to listen to a patient, and even if they're being yelled at. So that's amazing how that got turned around. So I'm wondering what you were initially thinking of it. So when you get yelled at by a patient, it's probably you're probably thinking, that patient can't be right. Let me find all the reasons why that patient is wrong. What was your process? I'm assuming you didn't just the same minute, start a low carb diet on yourself. You probably had some education to do on your own. Is
Well,
that right?
I was curious. I think that's a really precious thing is within clinicians, curiosity. I've always been curious about people who do well. And I think that's so important to learning. And she was very cross. She even wondered if I was properly qualified because she said, it's basic biology, Dr. Unwin, that starch is concentrated sugar. And you see, I cannot believe in your training you haven't come across this. And then the next question, I wondered where she had learnt it from. So I was curious. And it turned out she was one of 40,000 people on a low carb forum, and they were all teaching each other. And many of them, when I went online, were getting really surprising results. There were before and after photos. So my curiosity got greater and greater because I realized that there was something of a patient-led grassroots revolution going on here. And that when I looked into it, the actual physiology was sound because the best really, on the whole, the thing that predicts blood sugar is what have you eaten recently? And so that's reasonable. And in type 2 diabetes, what you're trying to do is lower blood sugar. And so again, I realized it makes sense to eat less sugary and starchy foods. And then when so many of them were doing it, so that I think I knew that what I was doing was not working well. In the practice, we had a 9-fold increase in the prevalence of type 2 diabetes since 1986. So that I knew that something was going badly wrong in society, and that our clinic, we were trying to stem the tide, but it was failing. And the results from the medications were often disappointing. I didn't see people shining with health. As this woman, in fact, she was so transformed, I actually didn't recognize her. It was very embarrassing because she looked so different. So curiosity, then the physiology, as I investigated it, was reasonable. And then I went on the diet and lost weight and felt wonderful, and my blood pressure improved and so on. And then we tried it on a trial, 18 patients. So my wife and I, with 18 patients, we said, we don't know what's going to happen, but if you want to try this, we did it all together. And that was the basis of the first paper that I wrote, because the results were astonishing. They were so good that I thought everybody would assume I was a fraud, and I was too frightened to publish for a while. But that's partly curiosity, I'd say, and an interest in physiology, and then just having a go and seeing what happens, but measuring everything. And because what we did was unusual, and because the partners in the practice disagreed with what I was doing, they thought it might be dangerous, and that we had terrible arguments about this. I kept careful data, careful results right from the beginning in January 2013. So that's 10 years ago now. And it's that data which has been so precious. And I think audit for clinicians is very, very important. And previously I'd hated audit, but for all of us to know what we are achieving in our clinics is surely important, and it helps answer interesting questions.
Absolutely. So that's interesting. You mentioned the partners in your clinic were all against it, and were giving you a hard time. Now, 10 years later, have they changed their mind? What's the current situation in your clinic?
The current situation is the majority of all of the clinicians in the practice are low carb and have been for a year or two. The practice manager has lost stones in weight. The midwife has lost 4 stone in weight. You don't think in stones, do you? That'd be pounds. So
No,
that's four,
but it
four
sounds
times
very.
14. So it's about 50 pounds in weight. And of course,
Wow.
we've now been on primetime television a number of times. We've been featured now by the London Times, by the New Scientist. We've been on Radio 2, Radio 4, Channel 4. We've had the Australian government sent a scientific committee to look at what we did. So the practice has now become quite famous, and the partners are enjoying that. And also, we've now got 20% of our entire diabetic population into drug-free remission. So we're saving money, about £70,000 sterling every year on drugs for diabetes alone. So that the partners are very enthusiastic because the results, they're seeing them every single week. So yes, it's been an amazing, we had terrible arguments, and now on the whole, we don't have cakes and biscuits at coffee time. We have almonds and walnuts because we're trying to practice as we preach, as you said at the beginning, Thomas.
All right. Wonderful. That's amazing. Maybe to clarify one little thing. So in the UK, you're in the NHS system, right? That's a little bit different from the US system where doctors often are in private practice and they have maybe more leeway as to what they can and can't do. But how does that play out in the NHS system? Did you get essentially pushback from the NHS
Yeah,
system saying, no, we're not paying for this? Did you lose money at the end of the day?
right. That's really interesting. So that yes, I'm working in the public sector, which is tough because we only get 10-minute appointments. I don't know what happens in the States, but I only have 10 minutes with each patient, and we have thousands of patients because it's the state sector. In the beginning, the problem was that all sorts of doctors and dietitians and healthcare professionals heard of what I was doing and didn't like it. I got hate mail, I was booed and hissed in public meetings, so it was very difficult. But then also this drove my passion with collecting data to prove, well, what was going on with the patients. There is quite a lot of freedom in the NHS as to how we help our patients. Quite a lot of freedom. Although I would say I personally have lost money for about 10 years because I've had to. The only way to do this was to work for free for a few years while I proved that it would work. But now it's all come good, and going low carb in the UK is broadly fine. We've come a very, very long way. So it's tough in the beginning, not so much now. I think we've had such a lot of media coverage. Mainstream media in the UK has featured our work probably about 50 times, and that has helped bring about the grassroots revolution and a lot of acceptance. And the Diabetes UK, the charity of accepting it now, and the dietitians. So we've come a long way. What I would say is I'm grateful now to the people who shouted at me because of the discipline of just checking. And as we're going to, this will have to come round to renal function eventually, I dare say. And that paid handsome dividends later on when we came to think about renal function.
Right. Good, excellent, nice segue into renal function. Because one of the major complications of diabetes is, of course, kidney disease, and diabetes is the number one cause of chronic kidney disease. So naturally, you would have had a lot of patients with chronic kidney disease amongst your patients. And you did something about it and kept track of their progress, and you published a paper, which we'll put the link down there, your key papers, so people can find them later. But you published a really interesting paper, which to me became really important because I think over the span of, I believe, 7 years or so, you kept track of your patients and their kidney function. And could you summarize what you found in those
Yes,
figures?
I'd like to tell you the history of why we did this because it's quite interesting. One thing the listeners need to understand in the UK, really the journey. So I am my patient's general practitioner, and on the whole, only their death or my death will separate us. So I have wonderful continuity of care. So I've looked after that population for nearly 40 years. I really know them. They trust me, but I have computer data. I find that in America, a lot of clinicians do not have computerized records. We've had fully computerized records for 20 years. So that data is continuous and reasonably high quality because it's all coded. So that's an advantage. So in some ways, we're much poorer in the UK, and in other ways, we're richer. So the computerized system and the continuity of care within primary care, so that I really look after a large proportion of the people who live around the surgery. Very high. So we've got the whole population, basically. So that's just a bit of background. Now,
Nice.
You're absolutely right. So my focus is on people with type 2 diabetes. And as part of this, in the British Health Service, you measure renal function once a year because we expect, of course, that most people with diabetes are over 60, and the combination of age and diabetes usually causes renal function to deteriorate over time. And in fact, we know that you would expect the EGFR, which is the thing that we tend to measure, to deteriorate by about units of 1.5 per year, something like that. That's what you would expect. But now a little twist in the story. I told you I was auditing everything, but we set up the Excel spreadsheets and the research spreadsheet, but we didn't. At the beginning, I was worrying about lipid profiles and blood pressure, but I didn't record the renal function. And then one day I go around the world, as you know, Thomas, giving talks, and I was in Ireland. And the thing with the low carb diet is if it's low carb, you've got to increase something else. So you're either going to increase fats, in which case everybody worries about cardiovascular risk and lipid profiles, or you're going to increase protein. And as the senior dietitian of Ireland said, you must be very worried about the renal function with all this protein, because it is true to say my patients tend to eat far more meat, fish, eggs, that kind of thing. And I realized I hadn't noticed a problem, but I hadn't really audited it. And so I thought, right, I better do this. So I went back through hundreds of patients because we did have the data and it just needed harvesting in terms of baseline and then latest follow-up for all the markers that we measure in the UK, creatinine, protein in the urine, and an eGFR. And this is the exciting bit because the results were exactly the opposite of what we expected. So we expected that you would see a slow decline in renal function for this group, particularly as the average duration of the low-carb diet was nearly 3 years. So over that time, with hundreds of people, average age about 65, you would expect a combination of age and diabetes to show deteriorating renal function. What we actually saw and published, for anybody that would like to read the paper, was the renal function improved. I was astonished and fascinated. And luckily for me, a professor of nephrology, Professor Wong, our local nephrologist, he'd come across a few of my patients and been intrigued by their improving renal function. So he'd got some of my patients and he'd watched as their renal function had improved. And some of them had come off insulin as well. So he was very interested. He came to the practice to meet me and said, "You're doing something very unusual. What is it?" And this was the basis of a friendship and the basis for the paper. And what we did was two things. So we also, because by now I've written a few papers, so we got a really senior dietitian in the UK, who's also one of the co-authors, to look at what is the historic reason that we believe that protein puts strain upon the kidneys, all this idea that protein is dangerous and you should avoid it, and the basis of some quite difficult diets as well. So the paper had two aspects. One was audit of service provision over years, looking at what happened to the patients, looking at the blood pressure, the lipid profiles. So we were looking really at cardiovascular risk with a view to what was all that fat doing, and then renal function. So we audited all of that. And then in the background, Dr. Guest, who was the senior dietitian, with Professor Wong, drilled down into the history. So first of all, if I could just deal with cardiovascular risk. So we found significant improvements in systolic and diastolic blood pressure, significant improvements in lipid profiles, particularly the triglyceride, and even more the triglyceride HDL ratios, which actually makes physiological sense because glucose gets turned into triglyceride by the liver. So, and weight, and of course, 50% of all the people who tried low carb achieved drug-free remission. So we got a really good improvements in diabetic control. So every single measure of cardiovascular risk that we looked at improved, which is very reassuring. Now we come to the what I find really interesting. So I asked, well, what was the basis of me believing that protein was dangerous in general for renal function? And an awful lot of it points back to a particular paper written by somebody called Brenner in 1982. And Brenner talked about protein causing glomerular hyperfiltration. So the protein was doing that. Now, the actual paper was behind a paywall, and normally I won't pay for any paper because I'm not like you. I have no academic status, so I have to pay for papers. Anyway, it was $30, and I paid it. But as I read it, I was more and more astonished. It had been cited by other academics 340 times as an absolutely key paper. But as I was reading it, he was talking about harbor seals, rabbits, guinea pigs, rats, and even vampire bats. And all these creatures were given weird diets, and then they noticed what happened to the renal function. But you know, it can't be a surprise that if you give a rabbit a high protein diet, that it's, you know, that's not really a good model for the human condition. And later on in the paper, Brenner comments that unfortunately they didn't have any human data. So how amazing. That's the basis of my belief. When I drilled down into it, was found to be largely based on animal studies. And I'm not an academic, but certainly, again, Professor Wong is, and I think he was surprised as well. But also clinically, he'd begun to suspect that protein was not always quite as dangerous as we had thought. And then particularly when you come to the population I'm dealing with in primary care, so many of them have a degree of renal chronic kidney disease, but I don't have many patients with really severe. So of course my work I don't know what would happen to perhaps almost your patients. I'm talking about people with mild and moderate chronic kidney disease in primary care. They, again, and the third point that I think is interesting is how did I miss it, this improvement? Isn't that interesting? And again, the medical statistician that works for free, Christine Dellon, for me, I asked her that and she said, what it is, it's a mild but general or ubiquitous effect. So I had missed it because so many patients had improved by a point or two, and yet the significance when they did the mathematics was very high. And certainly there were people who'd made dramatic improvements in renal function. So we had some people whose renal function was so poor they couldn't be started on metformin. You can't. So metformin is the commonest drug we use for diabetes, and they were, one particular person at least had to be put on insulin because metformin, his renal function was so poor, and he went on to come off the insulin and normalize renal function. So I think the question is, and maybe Thomas, you're the renal guy, well, what's going on? Isn't that odd and interesting?
Right. Yes, I think it's very interesting. So to recap, so there was a lot there. So you found not only, does your low carb diet approach, of course, improve overweight, obesity. It also improves blood pressure, hypertension, for many patients. But then, kind of like hidden in the data, because you hadn't specifically looked at it, there was also an improvement in EGFR, the typical, the common kidney function marker. And up to this point, I think it's been always kind of dogma that kidney function doesn't improve. I've actually had people, nephrologists, almost screaming at me when I say, "Oh, we're seeing, people improve the EGFR," and they say that's impossible. This has never been seen. you know, um, Improving EGFR means you have to grow new nephrons in order to achieve that. Somehow they believe that. um, so people start screaming literally when somebody says EGFR can go better over time. So I'm not surprised he got a lot of flack as well. But I would say, I mean, the proof is in the pudding. You have numbers. That means you have numbers. Um, but it's of course a really good caveat that you mentioned that most of the patients in your study were sort of mild to moderate stages of chronic kidney disease, and maybe it would be really interesting to look at more advanced stage patients. We have, that's anecdotal. We have seen actually also a lot of stabilization in those patients, and oftentimes that is, all you really need, just to stabilize someone, because the default, of course, is it gets worse and worse and worse, and you have to go on dialysis, you have to go on a kidney transplant waiting list, and that those are not fantastic options. So obviously, um, so that's amazing. um, so a question I have is, you mentioned already that most of your patients are probably somewhat, they're higher in meat intake and eggs, cheese, animal products. I'm wondering, how does the diet that you're prescribing, I'm not sure if you're actually prescribing it or recommending, is there a particular way of diet and lifestyle that you're recommending? Is it very loose? Is it very, people can essentially do whatever they want as long as it's low carb? How do you practically actually do it?
It's a good question. So if any of the listeners are interested, so all my papers are open access. We paid, so they're open access, and the specific diet sheet is there in every single one of them. So there will be a link to the papers, and you can have a look at the diet sheet. What we found at the very beginning was that the patients wanted not a book, but a leaflet, an A4 leaflet, and that basically is saying, turn the white stuff green. So instead of having bread, rice, pasta, yams, or whatever carbohydrate you have loads of green veg. And then we tend to encourage them to increase the protein in the diet. And we do include red meat. It tends to be not processed meat, though, I would say. Red meat, fish, eggs, chicken, that kind of thing. And we're not much more prescriptive than that. What we're trying to do is encourage people to eat proper whole foods and avoid processed foods, so that we do a lot of cookery lessons and that sort of thing within the practice. And we have written recipe books and so on and so forth. But most patients, I think, with diet, what's key is no two people have the same diet, Thomas. So my wife and I don't have the same diet. So what's really helpful is, I think our skill is helping patients understand the physiology of their problem and where sugar comes from and starch. And then they're in a position to individualize their diet according to their own beliefs, their pocket, how wealthy are they, And also, I want them to enjoy food. You can't suggest that people eat differently for the rest of their lives and not enjoy food. It's really key that they do, so that I'm not too heavy-handed with the specific things I want them to eat. I'm more interested in them understanding nutrition better and looking for nutritional density in food, and cooking from scratch. And that's been broadly what they do. And my patients are not they're all part of the National Health Service, so they're not especially wealthy. And I think another thing is motivating people. I'm often asked, well, why do your patients do as you ask and mine won't? And I think we're very good at the psychological approaches to behavior change, and that we don't just tell people to do things, we motivate them. And then the other thing is, part of the data collection is one of the key points to behavior change is feedback. You have to know how you're doing. And so we're monitoring weight, blood pressure, the blood tests, but we give feedback to the patients, often in a graphical form, so they can see how they're doing. I think it's absolutely key that you work with patients, and then you get better results.
I totally agree. Yes. You know, I think the typical patient experience that I hear about very frequently is that, the doctor tells them, I want you to lose weight, restrict your calories, do more exercise, and come back in 6 months. And of course, that doesn't work, right? So the patient comes back in 6 months. If they come back, is highly frustrated because they haven't lost any weight, they haven't improved anything. The doctor is probably frustrated because that same patient shows up over and over and over again, only getting worse. And I completely agree. There has to be coaching, and with all the things you mentioned, both feedback and some real explanations why somebody is doing something that they're doing, and even going a little bit into the science, I think is can be important for many people to have some confidence in what they're doing. So that's fantastic. So it sounds like actually for you it's a lot of one-on-one approach. You spend 10 minutes with a patient in your office one-on-one. There's a conundrum, of course, in the US, there's about 40 million people with chronic kidney disease and even more millions with diabetes and pre-diabetes. The UK has slightly smaller numbers, but we're talking millions of people, right? So if
Yes.
all these millions of people knock on the door of Dr. Unwin's office, there's no way this would work, right? So what is the solution for everybody else if
Right,
that's not your patient?
right. We've thought about that, and so there are two things. One is we've learned how to do group consultations. So we've been running groups of about 20 people for 10 years. But far more important than that is we've experimented with learning modules that can be accessed through the internet. So we were instrumental in doing a low-carb program that 460,000 people took up. And that will roll out. And then more recently, if any of the listeners are interested, there's a wonderful free app, no charge at all. So a young doctor has looked at my work and turned it into an app available on your phone called the Freshwell app. And at the moment, that's been downloaded by 35,000 people. It's reasonably new. And so these are the things, apps and the low-carb modules, various things, that I've helped produce quite a few of those. And it's interesting that there are now insurance companies who are looking at the cost of illness and the medication and starting to work with my wife and I. There's one group called Level 2 in North America, based in Minnesota, and they're looking into this because they've worked out you could have cheaper life insurance if you were less likely to be ill. And even more, far more famous is the Verta model in San Francisco. So the Verta people are also doing it all online without one-to-one. So people are often asked, is it, just the Dr. Unwin effect? But actually, there were also significant improvements in the low carb program, which you could hardly tell I was in, but I did help write it. So I find that very reassuring that it isn't just because I bully my patients.
Excellent. Yeah. And you have been very vocal in, as you mentioned, in public media. You have met many appearances. You're out there on Twitter, for example. And I think really it's in that sense a really grassroots process where it's partially patient driven, but also partially driven by pioneering doctors such as yourself. And I'm actually very confident that we will get there. That sooner or later, even there will be a medical discipline on however one would call it, ketogenic metabolic
I agree.
therapies, for example, anything like that. And you and I have been kind of trying to help out for me a tiny bit, of this Keto Live project. We're just trying to do exactly like that in the German-speaking countries, at least initially. Is there anything like this on the horizon in the UK that there could be a medical specialty that really focuses
Yes.
on metabolic therapy?
Oh, there's all sorts of things going on internationally. So there's a friend of mine is Professor Tim Noakes in South Africa, and he runs a thing called the Nutrition Network. And he got together an international group of people like me, and we have written the first ever keto and low carb doctors textbook, which will be published, I think, in about 4 weeks now. So that's a start, isn't
Wonderful.
it? An international textbook. And then on top of that, you and I are both so interested in the Keto Live thing starting in central Switzerland, where I love those conferences. I should be there this June, and so will my wife. The Keto Live movement is getting stronger. And then on top of that, I'm really interested in the work coming from Edinburgh, from Dr. Ian Campbell, where they're looking at ketogenic therapy and mental health, particularly bipolar disorder. And of course, Jan Bazuki has helped, or the foundation she runs, has helped fund the first ever professor in ketogenic therapies for mental health. So there's some really interesting stuff going on almost day by day. There's things going on and lots more research.
Yeah, so David, I think it's fantastic that you're, you know, kind of like almost transitioning, maybe it sounds like a little bit from, one-on-one patient practice to now going big and spreading the word in much larger circles, which I think we really need. We need, advocates for something that actually makes sense. And as you mentioned, physiology tells us, what we need to do, and it always baffles me. I'm teaching physiology in college, and it always baffles me why anyone would treat a diabetic patient with a high carbohydrate diet. That just doesn't make any sense. My hunch is in a few years from now, maybe a few decades from now, it will be considered medical malpractice to do that, but we're not there yet. But I think eventually people will just look back, just the same way we're looking back on lobotomies, that were used, whatever, 50 plus years ago. I think it's going to be exactly like that. We're probably right now at the forefront, at the front of the wave of things that are to come, but the wave is going to be there. Great. So, where can people learn more? Where can they go? Do you have some, websites that you recommend, social media
Yeah.
platforms?
Oh, Oh, yes, I do.
Hmm.
Before I get onto those, I'd just like to say a little bit more about the
Oh,
physiology.
yes.
And because when we looked into what was going wrong with the kidneys, I think we have underestimated how toxic a high glucose is at the level of the nephron. And of course, also insulin. So this is particularly if you're insulin resistant, you have high insulin levels, tends to cause sodium retention, putting blood pressure up.
Hmm.
So somebody with diabetes, poorly controlled diabetes, it is the blood sugar itself which is causing quite a lot of the problem. Another aspect is the way that glucose attaches irreversibly to proteins, causing advanced glycation products. And so that a high blood sugar is aging your kidneys. So the answer is to improve your blood sugar. And if the majority of your sugar is there because of what you eat, then rather than using drugs, it can be very logical to just cut back on sugar and starchy carbs. And that's the model from the renal model of physiology I'm interested in. I think is probably right that rather than thinking the protein is damaging your kidneys, certainly glucose, a high blood sugar, in fact, it damages the lining of all your arteries very rapidly. And I think that is why if you have type 2 diabetes, improving diabetic control is likely to improve renal function. But I just couldn't resist the physiology of
Right.
that. But you did ask me, of course. So the first thing, so many things. My wife and I are founder members of a UK, I think you call them not for profit, don't you,
Hmm.
in the States? We call them charities. So the charity that we helped set up is called the Public Health Collaboration, the PHC. And if you Google PHC and Unwin, you will find all sorts of resources, the diet sheet, various infographics, some of which have been downloaded millions of times and are translated into 17 languages. So the Public Health Collaboration is full of interesting stuff. Another thing is, I forgot to mention, but we should ask, why is it that intelligent people recurrently do stupid stuff? So why is it that we eat things that we know put up our blood sugar and injure our health? And really, my wife is a consultant health psychologist, and she has concluded that many people are addicted to carbohydrates. And that is just like nicotine, just like alcohol. They know that sugar will damage their health, and yet they struggle to do the sensible thing. So it's simple but not easy. And so, for anybody who feels they may be a carb addict, like my wife, she's written a book called Fork in the Road. And she's a psychologist, so this is from a psychological point of view about if you are a carb addict, if you don't understand why you've been a yo-yo dieter, why you keep going back to carbs when you know they'll give you a big belly and worsen your blood sugar. And that's available on Amazon. And that's also all the profit from that helps fund the PHC. Recipe books, there's loads and loads of great low carb recipe books. Again, you can go onto Amazon. We found a wonderful London chef and helped him reverse his diabetes and reverse his peripheral neuropathy. And out of gratitude, he's now written 6 low-carb recipe books. So if you look under Amazon under Caldese and Unwin, you'll find loads of recipe books. Oh goodness, there are loads and loads of podcasts that I've done. Quite a few in low carb down under. Very good. Well, I'm often asked about vegetarians and vegan and low carb. Wonderful website called D Life India has very tasty recipes for people who are interested in vegan vegetarian diets. I think the Diet Doctor website has a lot of very good recipes. So Diet Doctor if you can possibly come to the Keto Live conference in Switzerland, oh my goodness, what a treat that would be for anybody. And then you can meet Thomas and my wife and me. Oh, and my sister's coming this year as well. My goodness, that's a treat. Or go to the, again, low carb Denver or low carb USA. I think that, and look at, please read my papers and look in the supplementary files, because I pop everything in there that may be useful to clinicians wishing to replicate our low carb successes. So there's quite a few places to start with for anybody interested.
Excellent. We'll get all those links, put them down there in the description so everyone can find them. And of course, if somebody is seeing this video knows somebody suffering from obesity, diabetes, pre-diabetes, chronic kidney disease, do them a favor, maybe forward them a link to this video, and they can listen in and look at all the same resources as well. Great, wonderful, David.
I need to add in. I have to add in a health thing.
Oh yes, for sure.
And that is the health thing, and that is that what I'm supplying is I hope interesting information, but it's not medical advice, because I'm not your doctor. And so if you are on prescribed medication, you would normally make any changes alongside the prescriber, as I do for my own patients. And one thing you can do if you wanted to have a discussion with your own clinician is download one or two of the papers I've published, so that then you would go armed with why you're interested in doing this. So that's yours. I always have to put that in.
Right,
Sorry.
yeah, and that makes a ton of sense, because people, especially with kidney disease, are typically on hypertension medicines, and the low carb ketogenic diets, they're so powerful in reducing blood pressure. Somebody might actually,
Yes.
go overboard, or it's too strong together.
We also ought to put in. I have written a paper on insulin, low carb, and high blood pressure, because I think about 20% of all my patients had their BP medications stopped because their blood pressure improved so much. So one of the things about low carb is you can start feeling dizzy when you stand up because your blood pressure is low. So these things need monitoring times.
Yeah, totally agree. Excellent. Well, David, thank you again. This was terrific. We'll spread the word together as much as we can, and hopefully we'll reach people out there, and it might be helpful to them. Wonderful. Have a great evening in the UK, morning here, and we'll see each other at the very latest in Switzerland at the Keto Live conference there. Great. Thanks.
Thomas, thank you so much. A great pleasure. Bye-bye, everybody.